So I assume some of you came to this lecture to go home with a message who really you can refuse because there is no benefit to that patient. And again, this consensus statement that was published in JAMA looked at ICU triage, and the group stated that you may exclude these patients, whether a bed is available or not, in those patients with irreversible brain damage or multi-organ failure, unresponsive metastatic cancer, and you should exclude these patients, whether beds are available or not, a patient in a persistent vegetative or permanent unconscious state, a brain-dead patient who's not an organ donor, and patients obviously refusing intensive care. And this was updated by another group several years later, and basically they had the same reasons. So I guess several groups stating that these are patients who could not benefit. We don't have a lot of objective data, but certainly I think these are some of the reasons most of us would agree that these patients should not be accepted to the unit because they would not benefit. So what I've tried to do for you this morning, it feels like afternoon already after several lectures, is to give you an overview of the problem of benefit, to perhaps argue that sometimes our definitions, despite the fact we're physicians making objective decisions, are sometimes somewhat subjective, and it's very few patients that really have futile therapy. We should use futility only for those patients who have physiological futility. And it's very, very difficult to really define the patients who cannot benefit from the ICU. And I've given you some examples where there is consensus where we should not accept those patients because there's no benefit. Thank you very much.